Welcome again to another episode of Telehealth Startup and Secrets to Success. Again, thank you so much for everyone for tuning in. And today we actually have a record registration for NET. I think you guys will find the treat. We actually have, I think, over 550 registration as of now for this. I think it definitely is really, I think what NET's topic is pretty timely. I think NET, can you just share with us, you've been in the industry for a long time. Like, how did you get into telehealth? Like, what were you doing before telehealth? How did you?
Well, actually, I've been in telemedicine for about 6 or 7 years now, but I've been in healthcare IT for my entire career, 30 plus years in the business. I started out in Barnes Hospital in St. Louis. I was actually working in a clinical area, and I've always wanted to be involved in healthcare because it's important to help people. So I enjoyed that, and my plan was to stay in a hospital for my whole life. And then someone introduced me to computers, and I realized I was a geek. So I got into healthcare IT because I get the best of both worlds. It satisfies my geek side, but it also satisfies my helping people side. I've been involved with a lot of different companies such as McKesson, Merge Health, went through several startups, and most recently, I got into telemedicine about 7 years ago. I was brought in to help deploy a product to bring it into beta. And after I left that company, I decided it was time to start a consulting company and get involved in healthcare IT for telemedicine.
Super. How's the consulting life? I mean, it feels like right now, given all the need and just for things people to figure out, that must be a booming business for you.
It's actually great. It's really exciting. We have several different clientele that we're working with. We've worked with behavioral health centers. We've worked with physician groups, correctional health. We've worked with locum tenens groups, and we've even worked with telemedicine vendors who are trying to refine their product. So yeah, there's a lot of opportunities out there. It's at our point now, we're looking at how to focus in on one market. Maybe it's correctional health. However, we're also getting pulled at the same time outside of the U.S., where we planned on staying. We're working with a business partner for an opportunity in South America, and we're also looking at North Africa and another opportunity in West Asia right now.
Okay, exciting. This is it's really telemedicine all over the globe in there.
Exactly.
Yeah. And so I guess for the audience, for those people who might know, NET maybe on the non-healthcare IT side, NET is actually very active involving community theater for many years. In fact, he has the latest role is Jake's Woman, which require him to be on stage for nearly 2 hours straight. So you can see maybe acting theater side of him.
It's telemedicine on stage, yeah.
Excellent there. I guess in that, maybe you can sort of, maybe you could just share with us a couple of your insight and things. I know you have a presentation prepared. Well, maybe you could share with that. After that, we'll open up to the audience because I guess we'll ask you questions.
Okay. Well, let's move ahead with a quick presentation here, and we'll talk about how to go from a telehealth startup to enterprise. I know. First, we'll move on to a little bit about the reimbursement side. Now, I always tell our customers not to focus too much on reimbursement. It's obviously important, but it's more important to look for revenue opportunities in the telemedicine market. Look for cost avoidance. I mean, telehealth is a tool, and reimbursement doesn't pay for tools. It pays for the delivery of care. So telemedicine itself is not care. But you need to look for how you can differentiate telemedicine in various areas. So for example, in reimbursement, when we work with a group, we talk about state legislation, parity laws, medical board requirements. We always talk about payer mix, whether it's Medicare, Medicaid, or if you're just dealing with insurance groups. And we also look at what type of service you're going to provide, whether it's live video versus store and forward. But again, it's very dependent on state legislation. It's dependent on payer mix. It's dependent on a lot of different categories for reimbursement. So before we get into the reimbursement side, we like to talk to our clients about what to do before you begin. Why are you really getting into telemedicine? You know, I saw a study that said 43% of hospitals have telehealth capabilities, which I think is very, very low, because if you think about it, teleradiology has been around for a long time. I mean, I was in it 10 years ago, and many vendors such as Merge and McKesson have telemedicine, teleradiology solutions. And Nighthawk has been a great remote read company for several years. So telemedicine's out there and it's well established. So if you're getting into telehealth now, you need to understand why you're doing it. Is it to increase the quality of care? Do you want to collaborate with other physicians? Do you want to have faster access to specialists like stroke, or access from remote regions like pediatrics? Are you looking for a competitive advantage, or more importantly, are you trying to keep up with the competition now? Or are you trying to reduce costs and optimize resources? Are you trying to find a way to reduce the cost of transportation, or locum versus full-time employees to outsource? Or are you looking for revenue opportunities? Are you trying to increase your market share by reaching out to rural communities and getting a patient mix that you've never had before? You know, behavioral health is one of the areas we're in, and one of the nice things is when we get into a behavioral health center, we talk to them about these opportunities, and they're always like, well, we want to reach out to our patients at home, and we want to reduce physician transportation costs. In the correctional health, they're always talking about how do we increase the access to specialists? How do we reduce transportation costs? And obviously, how do we increase safety when moving inmates back and forth? So again, before you begin, understand why you're getting into telemedicine. Set clear objectives. What are your objectives for this, this implementation? Is it quality of care? Are you trying to reduce door-to-needle time on stroke? Are you trying to reduce readmission rates? In the case of inmates, are you trying to increase their access to specialists? And market share. Are you trying to reach out to rural communities? Are you trying to reach pediatricians like in a rural community? Georgia has a real problem with that. Not every county has a pediatrician. Are you trying to increase offshore access, whether that's reaching out to cruise ships, oil rigs, or even other countries? Are you looking for cost savings? Physician drive times, incredibly important in behavioral health. A lot of psychiatrists have to drive across state to reach out to patients. Well, that's there's two things there. One is the cost of the physician driving and staying overnight, and two, it's the lost revenue when the physician cannot see patients while they're driving. So also, are you looking for revenue opportunities, like increasing patient volume? Clear objectives, and build a good, strong program plan. Who is your team? Identify that up front, and don't overcommit. One thing that we've seen in a lot of telemedicine programs, they get to the point of ready to go. They've decided to do the assessment. They've put all of the program pieces in place, and even though they're not ready, they go ahead. So at this point, before you start the program plan, we always recommend take a step back. If you're not ready, it's okay. Don't overcommit, rethink the program, and do it right the first time. So identify your team. If it's a physician group, it's usually fairly small. If it's a clinic, behavioral health, or correction center, you need a steering committee, project manager, and you need champions in all the areas you're going to deal with, whether it's a physician, nurse, or administrator. Make sure your CIO is locked in on this. They're going to have the proper IT team, the network specialists and analysts. They're going to help you be successful. And make sure you have good trainers, super users, and someone in each department that's going to be the champion for the program. Assign a telehealth manager or coordinator. Those are incredibly important when you're deploying a system. Someone has to be responsible for this program. It can't be pushed on just anyone in IT or anyone on the clinical side. Make sure you put together a reasonable project plan. Time, resource, costs. And most importantly, in every telemedicine program, and I'll tell you, we've gone back into several programs that have not been successful, and we help them retool and rebuild their systems. But define what success is. Is it the number of patients seen? Is it door to needle time? Is it reduce the number of inmate transfers? Increase number of patients outside your county? So make sure you have a clear success plan and communicate this to your team. Let them understand how you're going to be successful, and make sure your management teams understands this. And then bottom line, measure. Make sure your results meet those expectations. If they don't, retool, restart, or stop. It's okay to stop at this point. You haven't committed anything. You haven't brought physicians in, clinicians in, and started to use a system. You still have time to go back and rethink it. The next step, however, if you're ready to go on, is vendor selection. Again, incredibly important. Are you looking for a software system or a hardware system? Understand the problem you're trying to solve. You know, it used to be hardware was important in vendor selection because compression algorithms weren't what they are today, or actually the network bandwidth isn't what it is today. And frankly, we see software systems have overtaken hardware solutions probably in the last 2 or 3 years. And they're so much better. They're so much thinner and lighter weight. It's easier to use, especially when we're dealing with behavioral health centers. Look for integration. Is there existing telemedicine systems in place or EMRs that you need to integrate with? Some EMRs now have telemedicine components, but you need to look at those carefully and see if integration with your EMR vendor is best. One thing we found is physicians do change EMRs. So if you've signed up for an EMR system that has telemedicine built in and you decide to switch EMR systems, well, you've lost 2 at the same time. So make sure you're looking at the product for something that may need to be replaced in the future. Easy for behavioral health when we're looking at systems because, again, it's a video audio. We don't need peripherals. But when it comes to equipment, understand whether you need carts in this situation. Everybody calls carts dinosaurs nowadays. But the fact is, if you walk into any hospital in the United States, you're going to see some computers on wheels, and they're used extensively. Nurses know how to use them. They know how to deploy them. So putting a cart in an ER or on a patient floor is not difficult. They already know how to deal with them. Kits. Understand whether you need a telekit, something for remote access with connectivity and peripherals that you can take out into the field. And understand what type of service you're going to provide. Do you need something for ENT? Do you need weight, spirometers, breath and heart sounds, some type of stethoscope? So understand all the peripherals you're going to need in dealing with that specialty. And then, of course, look for existing relationships in the organization. Are there contracts already in place that may be used also for telemedicine equipment? Some statewide contracts. In the case of correctional health facilities, we run into video court a lot, and there's already equipment in place that we may be able to leverage off of existing systems. If you've gotten to this point through vendor selection, it's time for implementation, and this is the fun part. We get to actually deploy the system. Are you going to pilot the system? And if so, are you going to do it in a single or multiple locations? Most of the time with a physician group, we're looking at a single location because they tend not to have 2 or 3 locations throughout the city. So the pilot's fairly straightforward. But if you're going to do a pilot, make sure you test as many pieces of the system as you can. Not every location, every region is going to support the same workflow. But if you can incorporate as many of those pieces of the workflow as possible in one place, you've met all your needs. Don't try to push yourself too thin during a pilot because you won't have enough resources to adequately support it. And make sure during your pilot you're paralleling to an existing system. Pilots can run for a day, a week, or a month. They can run as long as you need them to run to ensure that it's reliable. We've done pilots not just for one location, but for a region. For example, throughout Georgia, you can pilot throughout an entire state and achieve the same same success. And then you need to decide at the end of the pilot, are you going to move directly into live, or are you going to review what you've done so far and restart the program? Now again, full deployment is for the strong of heart. Very rarely do we do a full deployment for larger systems. We can do those for a physician group or a physician office. They're fairly straightforward, but full deployment can definitely drain resources and can be difficult to support. And look at training. This is very important. Make sure you have a program in place, whether it's a train the trainer program or train the full team. It's important to make sure that your staff is well trained, make sure they're checked off, and that they go in for refresh training if necessary right before they go live. Don't train too early, but also don't train too late. And support is part of the test system. So make sure that when you're piloting, that you test the support processes. Somebody will have a problem, whether it's a workflow problem, whether it's a system problem, or just a problem in general. They will want to call someone. Make sure your support processes are well tested before you go live. You don't want to test these after you go live. And then, after the implementation is up and you are live, which is the end game here, make sure you do a post-live review. We recommend those after 30 days and then quarterly for the first year. Review the support team. Make sure all of the tickets that are coming in with issues are resolved and worked through. Perform refresh training. Not everybody picks up the system initially, so you'll need to go back out and talk to them again and retrain that team. And review and revise workflow. It's okay to fix things. Go out there and evaluate how they're using the system. Sit with them for a day, walk through several of the telemedicine consults, and make sure they're using it the proper way. And then revise the policies and procedures if necessary. And then market your service. Get out there and tell everybody how wonderful you're doing. In a concierge system, it's less about selling this and more about notifying your patients of new options. It's a differentiator for a concierge group or a small physician group. In behavioral health, reach out to potential clients in your ads. More importantly, get your account managers to call referring physicians and let them know about your new level of service, that you can reach them in the home, that you can provide group practices, multiple groups together for one psychologist. And in a healthcare system, talk to your state legislatures, talk to your city council, go to your day at the Capitol and lobby your legislatures. Tell them about what programs you've put in place. Another important thing is market, for example, if you're doing a stroke system or you're reaching out into small rural communities, market to the EMTs. They're the lifeline of those communities. If they know about your service, they're going to make sure to use your service. And it never hurts to let the local news station know what you're doing. But avoid selling to those people who have already bought it. One thing we recommend and something we do on a regular basis is we meet with our congressmen and we meet with our senators and we tell them where we are with our business and where we're going. We educate them on telemedicine and telehealth. And finally, expand your service. Now that you've got it working, put in additional specialties. Are you looking to push neurology and pediatrics in addition? Are you looking to expand into new regions across state lines? Or are you looking for joint ventures? Are you looking to work with other physician groups and merge your services to provide better care and specialties across state lines or across the county? Discussion.
Super, Nat. Thanks for sharing your insight on this. So in your presentation, you talk about quite a bit of trainings and all these stuff in there. So how do you, how much time do you see normally for this sort of telemedicine for people to budget for training? Like typically, for example, for a provider, should you allocate, is it more like half an hour, multiple hours, or how much should organization think about?
When you're talking about a provider, a small physician group, it's usually an hour or two to train them on telemedicine. They're very straightforward in those types of implementations. As we get into larger groups and specialties, we tend to allocate much more time, and we'll do a presentation first for a group. Then we will do a detailed training for the team, and then we'll do refresh training right before the go live. So it does take a significant amount of time to get the training in. And significant amount is, by that I mean, it will take 1 to 2 hours for the first presentation, 1 to 2 hours for the training itself, and then it usually takes about 30 to 45 minutes for the refresh training.
Got it. How often do you do the refresh training?
You do it as necessary. What we recommend is, again, after you do your post-live analysis, after the 30 or 90 days, you perform refresh training at that time, because there'll be new people on staff, and there'll also be a lot of changes to the workflow, I suspect, as you make changes as you evaluate the system. So every quarter go in and evaluate whether they need additional training.
Got it. Again, I mean, do you feel like, so from our experience, the amount of training is required is actually quite a bit lower than I think the number you cited. I mean, do you feel like it's one of the reasons just like people are using product not designed for telehealth, but to use it for telehealth? This is why it's almost like you need a screwdriver, but all you have is a hammer. That's why you keep on having to get training, because it's such an unnatural fit. I mean, the reason I'm asking
that's an excellent point, and yes, you're correct. Sometimes they're trying to use what they have in place. So for example, we've gone back into systems that have telemedicine in place. They've used it for a couple of years. They got it on a grant, and now they're trying to retrain their staff. But the fact is this product was built for video conferencing more than telemedicine, and unfortunately, the policies and procedures that they put in place weren't built for telemedicine. They were built for teleconference. So they've trained these people, and now we need to go in and untrain and retrain.
Yeah, that makes sense. In fact, like what we expect as a lot of people we work with, if I say, right, like the question is, take Cisco, take Polycom, take things like VID, Wild, Zoom, all these, right? Which feature did they implement was designed for telehealth specifically versus just for general conferencing market? Tend to be like zero. And then you use these tools, and of course you find something is like, then of course they have to do all these training costs in there.
Exactly, and that's what you run into. Not every system is a telemedicine system. There are a lot of teleconference systems out there, and while they're great for the solution that they are supposed to be fit into, they're great for teleconferences. They're great for webcasting, for education. But the one-on-one with the patient, it's not built for that type of system.
That makes sense. So we really distinguish between teleconference versus telehealth system. I think they're different. I guess from your experience, like what percentage of telemedicine pilots are successful? Because people seem to be doing pilot everywhere. Do you have what is the industry numbers?
Well, it's hard to say successful, because you can go back and do the pilot over and over again. Yeah. Remember, we're running these in parallel. So if you fail at a pilot, I consider that successful, because you've learned from something, and you're not going to make that mistake when you take the whole program live. Exactly. Now, I'll tell you, our experience is probably about 50% of the pilots have serious enough bumps that we need to stop instead of going directly live. We have to step back, make some changes, and then push ahead with the go live later. But that's good, because not only have we learned from that experience, but our customers now know what their true workflow is. Many times they uncover workflow abnormalities in their processes that they wouldn't have known about if they hadn't implemented telemedicine.
That makes sense. So what were so these were 50% where you had to sort of put the brake on and rethink, what are some of the top reasons?
Well, and it's a variety of reasons. So you'll see training as one. There'll be a group that may not have received adequate training at part of the company. You may have some physicians that push back and decide, and we've seen this more than once, they've decided it's too difficult to do telemedicine. They can't take notes at the same time that they're performing a conference. So many times we do a lot of hand-holding with them, and we make sure that the physician champion spends time with them. We've had a couple of situations where bandwidth was not adequate. We did the math, but when it came down to actually pushing the system out, we had to make some changes to the equipment.
Okay, that makes sense. So when you work with your partners and customers, what would you advise them as, or if you're going to do a pilot, what should you set as a metric of success?
Well, the metrics that, and again, it depends on the practice. We recommend either a certain number of patients come through the system, okay, or a certain amount of time is elapsed. But you should always measure your success as that the telemedicine consults are successful. So you look at the end of the consult and you ask the patient and you ask the clinicians, was that a successful consult? Did you have problems with equipment as technology? Did you have problems using the system? Were you unable to take notes? Was the patient disappointed in the quality? So that's really the measure of success, especially when you're working with a physician group.
Got it. That makes a lot of sense. I guess in terms of like, so when telemedicine such has a huge range in there, like for example, like how will you, when you advise your partner, like how much should people budget for like telemedicine? Like for example, like one of the things we always recommend, you should always pay for consultants because chances are, right, you're going to save a lot more money by having consultants teach you what to do versus going down the wrong track. Like, I mean, how much should typically organization think about to want to do telemedicine? How much they should budget for consultant? How much they should budget for like technology, hardware, and software?
Oh, well, that's the percentage is really varies by a lot of different in a lot of different scenarios. Consultants are actually the cheap side of the business. Yeah. We don't charge that much compared to technology and especially software, hardware, and we don't cost as much as their internal resources. Internal resources are really the big budget item for many of these installs. Because if you look at technology nowadays, software is fairly inexpensive. You're paying for the ongoing service, but 5-6 years ago, it isn't uncommon for groups to be paying $10,000 for telemedicine monthly services for a hospital or a rural health center. We went into a behavioral health center that was looking at spending $2,000 to $5,000 a month, and we were able to come in with an equivalent solution for about $250 to $500 a month. So it just gives you an idea of the differences. But budgeting, it really varies. And it varies, for example, on a county basis that may have a contract in place. Percentage-wise, I would say the consulting side is about 10% of the overall project. Hardware and technology is probably about 30 to 40%, and internal resources use most of the rest.
Nice. Okay. I guess do you have like a absolute dollar range? For example, if someone to do a telemedicine project, like how much budget should they allocate to do it? Like to do it well. I mean, not just like super inexpensive, you know, but still, of course, also not super expensive. Just something order magnitude you feel like then they can actually.
Well, okay. I'll go back to the tiers that I've talked about over the years. There's really 3 tiers of telemedicine. There's the high end, the fairly expensive, where you see with that are cart-based, that have been around there for probably 10 years or more, that may charge $10,000 a month per service. And that's one solution. And the carts are very expensive. Although the prices are down, they can spend any place from $10,000 to $30,000 for a cart. There is the low end, which I look at as the equivalent of something like a FaceTime or Skype for the office. And those usually cost $50 a month per practitioner. And then there's the mid-tier. And what I've seen is the mid-tier has really become the solution set for most of our recommendations. That's the fit where there's high quality software, they've been in the business for several years and have a solution, and you can usually, per provider, get a good solution for $200 to $500 per provider. And that's really a great opportunity. It's not expensive, and it allows them to budget adequately based on the number of providers they have.
Really appreciate it. Thanks for these insights. So I have a question from the audience, Rohan. He's asking, so what percentage of ambulatory visits will you estimate are addressable by telemedicine?
Oh, for which type of system?
Ambulatory visits.
That would be a tough one for me. I wish I had an answer for that, but unfortunately, I really probably can't give you a reliable number for that. Remember, we're looking in a little bit different industry than what you're asking for there. Remember, our correctional health and our behavioral health might not fit the same mix that they're asking.
Okay, that's fine there. By the way, so I think for this, if you have any insights, we'll publish all the questions on there. We can again, when people
Yeah,
come.
we look at that question later, I'll have one of the partners look at that and see if they can come up with an answer.
Super. Okay, Rohan, please tune in to watch the recording later on. We'll give the answer for you. We have another question from the audience. Yes, he's asking, so what are some of the greatest barriers encountered by telehealth companies when they're working with physician group or hospitals?
Physician groups, I'll tell you immediately. It's the fact that they put in EMRs within the last 10 years, and there is a bit of hesitancy about putting any new technology in. So you'll see physician groups saying, we already put something in, we struggled through that, we're not being reimbursed adequately, I don't want to deal with any more technology. So there's a little bit of frightened response from using technology in the physician groups. As you get into larger healthcare systems, they're looking for basically return on investment. And while that can be overcome with cost savings or cost displacements and potential revenue opportunities, you need to be working with the CFO and understanding what basic limits they're putting on new technology or new implementations for their service. And they're usually the barrier. So if you can work with the CFO and understanding how to get through those barriers, it's fairly easy to work with. But in physician groups, you just have to sell them on the technology. And what we have done recently is explain to them that if they don't implement telemedicine, they may not increase their profits or be able to reimburse the same, but more importantly, they won't lose their patients, because many physician groups are losing their patients to bigger companies like American Well and Teladoc, who are doing telemedicine with insurance carriers. And the small physician groups are losing out there.
Got it. That makes sense in there. We have another question from Wallace. So he's asking us, so from your own personal experience, so what are some of the biggest challenges when you do telemedicine in remote locations?
Well, the biggest challenge, technology. Many of them don't have adequate networks. Okay. So I've actually worked in hospitals that did not have wireless in the ER. So that's one big challenge to overcome. Two is you always have to have someone out there in the initial implementation to train and to walk through the process. So not only do you have to have staff locally to support your physicians that are providing the specialty, but you have to have staff in the remote location that are properly training and monitoring the consults to ensure that they're highest quality. Once the team is in place, it's much easier. But its resources need to be on site, and new technology needs to be added, or technology needs to be upgraded.
Okay. Super. We have another question from the audience from Narita. So she's asking, so how will telemedicine startups like Teladoc, MD Live, American Well stand in the sort of same place where now you see hospital, clinic, and also they're offering their own telemedicine services in there? Like, how would that marketplace shake?
That's very interesting. Well, you've seen Teladoc and American Well are working very closely with the insurance companies. So they are actually moving into the primary care world much faster than the hospitals are. I think there's always going to be that separation, because the hospitals group are primarily working business to business. They're dealing with other facilities, other hospitals, other clinics. American Well and Teladoc are working with the consumer. They're trying to get out to you and me to provide services. So for now and the foreseeable future, I see those staying on separate paths. They may come together at some point, and I would suspect it would be American Well rather than the hospitals reaching out into the consumer market. I would see American Well more likely and Teladoc more likely reaching into some of these bigger installs and possibly providing services like neurology or specialist services.
Okay, so you're betting on the Teladoc, the American Well, they will win out over the
I think you'll see that over time might be the direction. And you know, I'm basing that a little bit on what I saw in teleradiology with Nighthawk. They they had their own neurology service, which people questioned whether it was going to make it. And they expanded throughout the US and then throughout the world, providing teleradiology reads.
I see. Okay, got it. Because I think for my intuition, almost like I'm sort of betting on the healthcare system in there because they have the natural escalation in there. They have the strong brand in there, and also on top of that, like company like Teladoc, American Water, they're losing massive amount of money right now each year, right? So then it's almost like it's hard to sustain that business versus the healthcare system. They have a deep pocket, they have the cap, so they can actually last longer. It's almost like.
Well, I share that with you, Milton, because coming from the hospital. That's where I'd like to see it go, and I feel there's some incredible physicians in there. However, this is the real world and the real market, and you'll see that companies like American Well, since they've already made it into the insurance business, they probably can make it into some other areas, and it may be through acquisition over the next few years.
Got it. Okay. So I have another question from Richard. So he's asking us. What do you see as the pros and cons of sort of embedding telemedicine capabilities so inside the EMR, like more like a deep integration versus more like agnostic approach, almost like standalone telemedicine with the EMR, maybe do some very light integration in there? Do you have that?
Yeah, and I touched on that briefly. When you're integrated with an EMR, it's not necessarily bad, but it keeps you from being able to substitute your EMR or any other product that you have in there that's integrated. So if your EMR has telemedicine embedded in it and you want to switch EMR vendors, you have to switch telemedicine at the same time. And the deeper the integration goes, the harder it is to switch. However, in fact, healthcare IT was like this 15, 20 years ago. There were a lot of separate systems, lab systems, radiology systems, financial systems, and you've seen them start to come together for integration, and the perfect example is Epic. Now, they seem to do quite well with integration, although there's still some other companies out there, like McKesson and Cerner, that aren't as tightly integrated in all situations. So it's a mix. I would, as a primary care physician, be hesitant about purchasing a system that was too far integrated, because I couldn't then make choices later on.
I see. Okay. But in terms of like these EMRs that offer this for like a deep integrated telemedicine, do you see which one you feel like the more successful, the guided user, the user adoption?
Well, as far as EMR systems out there, we really haven't looked at too many that have telemedicine associated with it, because we go from the opposite end. We're looking at telemedicine and how to bring those in around EMRs that are already in place. But again, I'll bring up Epic as a perfect example as a company that has worked with a couple of groups, such as Video, that's the one with the Y, in bringing telemedicine into some of their larger clients.
Yeah, got it. Okay. We have another question from the audience from Deepak. So he's asking, so are there any sort of telemedicine compatible hardware for using things like the ear exam, listen to the stethoscope in there? What is the cost ranges like?
Well, and it widely varies. It depends on whether there's licenses involved on the stethoscope and otoscope. Yeah. One of them that we've seen up and coming, and I know you've probably seen it too over the last couple of years, is TytoCare. TytoCare is an integrated solution at a price that is reasonable for, and I'm not selling them because I'm completely agnostic when it comes to hardware, but we've seen them at the last few shows, and they have a version for the practitioner, for the provider, which is quite well put together, and they also have a home version that we're really impressed with. It is low cost enough that can be used in the home, and eventually I see companies integrating with TytoCare and allowing a mother or father to do some ENT exams at home and not having to take them into the pediatrician. I could just imagine if a child had tubes in and was now having suffering from earaches at nights again, and you could actually use this device to look in their ear to determine whether they did have an infection. You would never have to go to the physician office, but you could call in a prescription and pick it up a few minutes later.
Got it. Makes sense. Do you feel like how low could the price point become? Do you have some prediction within the next like 2 to 3 years? Because the reason I ask is feel like as an average consumer, all the the suite of devices out there, they still feel like a little bit on the higher end for like a average American family to just go out buy one.
To buy a device to use in the home for telemedicine. I'm guessing that once a couple of these companies come out, we're going to see a below $200 price point, which is still a little bit high. But I'm guessing the next step will be insurance companies reimbursing for having some of these devices in the home.
Okay, I think that will help a lot because I know like these are a lot of these hardware companies that getting the supply chain, the quality, and get the margin is a brutal business. That's why you see company like I think Salesco was one of our favorite for a while, but now they stop making like for newer device. I just feel like almost like want to cheer the devices on to make get the margin, figure out how to make it work.
I definitely am not going to pay $1,500 for an e-stethoscope at home, but I would look carefully at devices once they hit the below 200, and I certainly would, just like insurance companies subsidize Fitbits, as do employers. I think they're going to start subsidizing these.
So I have a question for Marie from the audience. Is like, what's your perspective on occupational medicine, application telehealth to that stage?
I wish I had an answer on that. We really haven't looked at that side.
Okay. The next question from Rohan from the audience is, so what percentage of behavioral health visits will you estimate can be done by telemedicine?
Well, in the area where we were looking, there was up to 80% of the visits could be handled by telemedicine, but that was after seeing a physician first. So it was follow-up care. It was not the initial care. They even were experimenting with group sessions handled through telemedicine, especially for some people who had fears of coming out into the community, but were still able to reach out to these group sessions from their home.
So I think our experience that we were actually exhibiting at the American Psychiatry Association conference maybe a couple of weeks ago. We had met a bunch of psychiatrists. It was interesting. It's like there's a bunch of these psychiatrists that are like, yeah, this is like I could do this like nearly 100% in there. Then there's also a pocket of psychiatrists that they really need that, that human presence, that touch for them to be effective. And my hunch is maybe it's even like particular based on how the psychiatrist trained, what they feel comfortable with, and so on.
Well, and that's interesting. We one of the first installs we did, I remember training a psychiatrist who was over 80 years old, and I was concerned that he would have no interest in performing telemedicine consults remotely, and he was one of the biggest adopters because he no longer had to drive 2 hours.
Okay, super. Yeah, I think for the patient convenience, it's definitely huge. So I have another question from Janet from the audience. So she's asking, will telemedicine work for a single provider in a private practice providing therapy service? And then if so, what is like the best sort of like almost a software you recommend for something like a single provider practice?
Well, for a single provider, yes, it will work. But you need to decide what type of consults you're going to provide to your patients and how you're going to either charge them or you might want to give it away for free as an add-on service for your consult. But the best software for that, there's a lot of them out there. And the only thing I would recommend is it has to be very light. It has to be something that they can use in the home. So you don't want, obviously, hardware. You don't want heavy software. You don't want to install too much on the machine, and it has to be able to handle low bandwidth, because let's face it, most of the people you're going to deal with in the home are not going to necessarily have high-speed broadband. They're going to have their own wireless systems, which may be fairly low at this time. Most of us are up to wireless N at this point, but not everyone is. So there's a lot of vendors out there. I would say if you want to go through the list from ATA, that's a good place to start. But my recommendation when you're starting out something in a small physician practice, again, don't buy something that has too many bells and whistles up front. Get used to it. Don't try to buy an EMR. Buy a solution that works well with your EMR.
Okay. So then in terms of these were like a solo single practice, I mean, earlier you mentioned these were different tier of pricing. There's like things that cost around $50, things that cost like $200 to $500 range. I mean, would you recommend like to do the $50 range for these for a few $100 range? Or
No, again, we're sold on the mid-tier right now. There's very few at the low-end market that have been around long enough to provide adequate customer support or have proven themselves in customer support. Not that they won't get there in the next year, but they're trying to competitively price right now, or they don't understand what it's really going to cost to do business in this market. The mid-tier, I believe the mid-tier is where it's at right now. It's a very strong market. Most of the players in there have been around for several years, and they have good, strong support organizations.
Good advice in there. So the next question is Brighton from the audience. So he's asking, so in terms of for the dermatology in there, especially for the small group, have these group find telemedicine profitable?
Well, we have no experience in dermatology, so I'll tell you we haven't worked with any, but from the people we've talked to, yes, there have. That dermatology is successful, and in fact, there are some dermatology-specific software applications that you can look at that provide store and forward dermatology, which is very useful because it obviously allows the patient to take photos, send them in, and it's not a real-time service. So it's worth looking at something like that, especially if you're a small practice, one or two within your practice, and your patients are not going to be using a high-def camera at home, but probably taking a picture with their phone or something similar.
Okay. Then if we could go back to in a general space about profitability in there, so for example, you mentioned earlier working with a CFO and so on. So when a healthcare system or a medical group think about telemedicine, how much margin should they aim to have out of these telemedicine service?
Well, again, we recommend that you look at how to provide a quality level of care, and you're not looking at the margins up front. It's important to be looking at break even initially, or providing the ROI based on cost avoidance, not on increased revenue. Look for ways to save money up front rather than increasing profitability. Once you get a stable group in place and a stable system, then you can start looking at how to increase margins. And really a reasonable approach is to look at a 5% margin after the second year and see if you can pull something out and then slowly increase from there. But more importantly, let's try to cut the costs out and show an ROI based on costs alone. And in fact, that's how most of our assessments are done.
Okay, that's good advice. I mean, do you see people for example, you have this low-cost national sit out there like the Teladoc of the world, around $49-ish thing. From our experience, mostly healthcare systems, you provide at that rate, they actually are losing money in some sense in there. And do you feel like they've been pulled out by 5%?
Well, that's a good question. I mean, you have to look at a lot of the telemedicine companies that are out there and the providers and question whether they're profitable at this point. Mm-hmm. Look at even some of the big groups. Look at Mercy Health in St. Louis. Where they spend 80, 90 million for their virtual care center. Yeah. I'm guessing they don't have profits right now, and they probably won't show a profit from that for many years. So what they did is they went in with an idea, with a vision, and understanding that they were going to lose money for a few years, but this is where technology will take them in 5 or 10 years. And in fact there's going to be fewer patients in the hospital. Most of the people are going to be seen in outpatient, and that's where your surgeries are going to be, and most of the care is going to be provided in the home.
Got it. That makes sense. I mean, in some sense, my biggest worry is if you look at the Teladoc, right, last year they had about $123 million in revenue. They lost about $62 million. Like a similar thing for these American Well of the world, in there, right? I mean, then if you're Mercy also losing money, then eventually you feel almost like anyone who's famous, they're losing lots of money in there. But do you see certain companies out there, they are killing it, they're making boatload of money in this space?
Actually, no. I don't see anybody out there doing that yet. But again, this part of telemedicine is new. If you look, however, at some of the older telemedicine implementations, And I'll go back to teleradiology again. They're killing it.
Okay, got it.
You can't expect your profits the first couple of years. And look at us, we've been around for several years. But the fact is the startup zone at ATA is still loaded with people. And if you come back every year, probably about 50% of them don't show up again.
Okay.
So it's still a revolving market.
Yeah, it's a brutal business to be in. One of the things I want to chat about, so you mentioned one of the things you do in your the service office is to fix up all telemedicine implementations in there. So what I thought is really intriguing, given just how much millions of dollars these healthcare systems have spent on there. So what are some of the scenarios I've seen in which people didn't plan properly, or they could things they could avoided to getting to that like point of failures and like another thing, for example, a lot of that we see is people that have all these legacy equipment, from Polycom to InTouch, all these different things they spend millions of dollars on, and they're like, do you advise them just check it, dump it, restart from scratch? You put Band-Aid solution, what do you do?
Well, it actually really varies, and yes, we see a lot of graveyards out there of telemedicine equipment. What we've seen is a lot of these systems were put together through grants, and everybody calls that telemedicine crack because people sign up for it right away and jump on it, but unfortunately they don't plan with those. They have the dollars to spend on it, but they don't always plan well, and they don't always allocate funds to put together a good vision. And let's face it, a lot of these are 5 to 10 years old when people were just trying to jump into the market quickly. So what we see is they've got the equipment still there. Most of it still works, but they need to go back and reevaluate what they're trying to accomplish. And sometimes we scale down what they're trying to do, and we provide adequate training, and we ensure that the equipment works properly. And in some cases, we tell them walk away because they just don't have the equipment and the people to move ahead.
Okay, got it. Okay. So in terms of maybe focus on making money again. So what are some of the successful revenue models you have seen, and how do you even go about maybe deciding the revenue payment model that you should use if you're, let's say, a medical group or healthcare system?
The revenue payment model. Let me look at a couple of things that one of my partners talked about earlier. He said, as we talked about, he said, make sure you understand the parity laws in your state. And most of them are in place. Make sure you understand your insurance mix. And that's very, very important as you're moving into the telemedicine world. Otherwise, you won't be reimbursed properly. Look at what you're trying to provide as a service. Are you doing live video on every consult, or are you doing some store and forward, which won't be reimbursed? So we recommend that people really evaluate what their current mix is, and then figure out which pieces of that mix telemedicine can replace. I mean, if somebody's calling in for renewal of their medication for an ENT problem, an infection, perhaps a consult would be better in that case, and allow them to evaluate the patient, and there's a chargeable service there just as a live visit. So there's a lot of opportunities to look at.
Great, thanks. We have another question from the audience, Wasim. So, I mean, there's a lot of stuff about obvious things like telepsychiatry, behavioral health, all these. I guess if there are specialties of medicine that has the greatest need for telehealth, maybe beyond this, where obvious things everybody talks about in there, that's where so far it's least covered by vendors out there.
Oh, least covered by the vendors. Well, the least covered by the vendors is veterinarian care, but it doesn't really fit into our mix right now. Right now you're seeing telepsych take off. It's actually been around there for a couple of years, and I see that as one of the most open up markets currently. There is also an expanding area of teledentistry, and that seems to be getting some ground hold right now. So we've talked to some dentists that are interested in providing some oral care follow-up and things along those lines. But there's a lot of open market out there. We've talked to groups about MS and follow-up care on that, hospice care. there's another area that's very important, where family members can meet with someone in care, and also the providers can meet with them and care for them. So there's a lot of open markets out there.
Okay. Nice. I have another question from the audience, Dean. So he's asking, so how have you dealt with IT departments that sort of insist on integration? You know, particularly for these large hospitals, the IT, they want to say everything integrate all these things, versus sometimes there's all value, of course, for these light standalone things.
Well, healthcare IT groups, especially in the hospitals, you know, they're focused on providing care for their group internally, and obviously they want to have something that's tightly integrated. We usually work with them rather than against them, and if they have a good solution, we'll try to assess the system and ensure that they can implement something that they feel is best for their program. We try not to push against the IT group unless it's really in their worst interest to move in the wrong direction. We've talked to groups that have decided that Epic is the best way to go with their telemedicine needs, and frankly, it was. They had the system in place that could add on this new solution with a fairly low cost. It made sense. So if your IT group has really drawn the line in the sand and said this is the best solution, unless they're making a horrible mistake, support them, help them implement it, and help them cost justify it.
Got it. Okay. Okay. As we're wrapping up the session, Ben, thank you so much for a fascinating information-packed session. So if I mean, you share with many interesting things, and so if the audience can only learn one thing from you today, like what should that be?
One thing from me today.
Only one.
Do telehealth for the right reason. Increase access to health care. Increase quality of care. Don't do it for the wrong reasons and just trying to increase your market share or revenue, because it will always come back to bite you. If you do it for the right reasons and try to provide better care to patients in the community, you'll find that the revenue follows.
Okay, got it. The next thing is, so what is something in telehealth that you believe in, but the rest of the world and industry doesn't believe in yet?
Well, I don't know if it's unique to us, but we've never been fans of kiosk care. Okay. So the retail-based telemedicine, telemedicine in pharmacies, we've never seen that as a really great opportunity. I mean, it's nice, but the fact is most people don't go to Target or Walmart looking for health care, just like they don't go to Walgreens to provide health care. And in fact, if you're going to drive somewhere and go to a telemedicine consult in a pharmacy, they're probably going to drive to an outpatient clinic and see a physician face-to-face. So we really struggle with how kiosks are going to catch on, especially in the retail market, where it costs a lot of money to put a kiosk or something taking up valuable floor space for product.
That's really insightful. Maybe that's one of the reasons that the health spa died. It was fundamentally the market just didn't make sense. Exactly. And the final question is, given all the craziness in Capitol Hill, all these, like this healthcare in there, so if you have the power, a magic wand to do like one thing, you'll just get done, what would be that one thing you'll do in terms of the healthcare? Wow.
Well, I know magic wands don't always work. So something we did a few years ago, we actually met with Tom Price when he was my congressman, and now obviously he's the HHS. We brought him in to talk about telemedicine, and he was very receptive. And the one thing that we both agreed on is there should be a national license. And I know this gets into states' rights, but the fact is he was all for that. There should be a national license to allow physicians to work across state lines so they can provide care without having to worry about whether they're in, Augusta, Georgia, or North Carolina or South Carolina. They should be able to provide care across state lines. I mean, the VA's been doing it for years. Why can't all of our providers?
Got it. That would definitely help a lot. Again, and thank you so much for this amazing hour in there. And for the audience, I apologize. I know there's like a bunch of questions we couldn't get to, but we're going to post this to Ned. We're going to post the answers on the side. Again, so in 2 weeks, we have Alex come in. I highly recommend tuning that in. You can see some really explosive, controversial, just really thought-provoking things, especially around the business, marketing, and just how you think about this space in there. And then also for the audience, I would recommend to start considering. So we'll have our physical telehealth fair, Secrets to Success conference. Will be held in the Silicon Valley in September 20th to the 22nd in there. Again, so if you want to meet more people like Ned, like the whole industry, definitely please sign up. You get early bird pricing now. It's going to be a blast in there. Again, thank you so much for audience for tuning in, and Ned, thank you so much for sharing.
Thank you for having me.